pediatric ward, those are also counted in those 721, which is also very important when we come to the number of patients that we actually serve at the moment. To give another idea of the amplitude, we have 30,000 admissions to the hospital into these 721 beds, and also 360,000 consultations on a yearly basis. So that's what you can expect from a hospital like us. We are working closely with the Vrije Universiteit Brussels, the university. So we have a lot of trainees, we have a lot of students, and also a lot of professors to guide all these people. So that's to present the organization. I'm a medical doctor by training. I'm a medical doctor in laboratory medicine. It's a bit of an unknown specialism, but now with the COVID, all that has been going on with the testing, well, that's in part what we are doing, but I have not been doing that for the last year. I'm working at a management level at UZ Brussels, supporting them and also supporting the crisis cell that we have around COVID-19, and which is, you can imagine, has been very active the past few months. The crisis has been active. Maybe you have heard of our hospital in the press also. We've been very active there to alarm the general public, but also to alarm the politics that we saw this coming a few weeks and even months ago. We saw more and more patients. It was not really a flood yet, but with our experience and looking at the numbers, we really felt that this was going the wrong way. And here we are a few weeks later. So we have had actions to sensibilize the political world about what was going on. But alas, maybe they were a little slow in what has happened. But that's a whole other debate. I let my CEO, which you see here with a face mask, talk about that. You can also see some things on TV. So I would just like to structure the talk in two distinct parts. I've been asked to talk about the virus, and there I will just estimate that people don't know what a virus is. So maybe this will be too easy for you, and then it's good, then you're up to date. But if you still have some questions about really what is that, what is going on, what is this little bug, and how does it work, then maybe this can help. We'll have a bit about the transmission and the prevention, but then the main part will be about the impact on the hospital that this little bug has. So just to start, the idea of what a virus does, we have to imagine that a human body is just a large collection of cells. Cells. Your skin is different from your stomach, is different from your bones, is different from your blood, because these are different types of cell. It's written in our DNA, which is a little structure inside the cells, how these cells should be formed and how they should function. But there is a way to visualize some cells. I guess you've all heard about red blood cells, white blood cells. Well, if you put some blood under a microscope and you read it a little, well, you can see those blood cells. It's very, very small. You cannot see it with the naked eye, but you can see them with a microscope. And our body, the human body, is just a collection of cells working very well together. You need the skin cells to keep everything inside and safe, but you need the cells from your stomach and from your guts to digest food that will be necessary to keep some cells alive, from an example, from your brain. And I hope I will not bore your brain cells too much with this explanation. But still, it's important to have the idea that you have a very different types of cell in your body that have a very specific function and work very well together, actually. So that was what I've been saying previously. With the naked eye, you can see the organ, for example, the lungs, the brain, the heart. And you can imagine something with that. These organs are formed by different types of very specific cells. Lung cells form a lung, to keep it very simple. And the cell is much smaller than the lungs, of course. We said that you have to look through a microscope to see it. But even smaller than that, even if this would be the actual size of a cell, we would still not be able to see a virus. I would dare to say a virus has a microscopic size, but not even microscopic. even smaller than that. And it's a living organism in its most simple, yet dangerous and effective form. So to go to the next level here, there are very much different kinds of viruses, and a way, like you have very different types of dogs, you also have very different types of viruses. A Labrador is not the same as a German Shepherd, and so hepatitis B virus is not the same as HIV, it's not the same as COVID-19, but they're all viruses. They're all very small organisms that actually penetrate cells, will then feed on what's inside the cell, try to corrupt the cell. And once the cell is filled with little new copies of the virus, the cell will die, and then you will have had one virus who has infected one cell, but you will have thousands and thousands of new little viruses that can then infect each and every one of them a new cell to form new viruses, and so on. So you see the mechanism. And that, in a way, is how, for example, the lungs get damaged. And you have a virus infecting one cell, you can say, okay, if one cell dies, that's not a problem. You have a lot of cells in your lungs. But if that process repeats itself too many times, you can really have damage to your lungs. COVID-19 is a virus which attacks the airways and the lungs. So it can attack the throat, it can go down through your throat, and it can attack the lungs. And it's very dangerous in the side of your lungs. So you have, that's one thing, the damage that the virus does to the cell of the organ. On the other hand, you have your immune system. So every living organism and every functioning human being has an immune system to protect itself from attacks from outside. So you have the immune system that after a while will recognize that something is going on, will recognize the virus and attack the virus. Now the problem with COVID-19 is that often the immune system will overreact. It will recognize the virus, it will attack it, but by overreacting it, will actually also damage the lungs. So it's a difficult interplay between a very small organism that infects you cell by cell, but in an expansive manner, and also your own immune system that by overreacting tends to hurt you more than it will cure you. Now, in much cases, and you will all have heard of people who have had COVID-19, who were sick, but who were not too sick by it, there the immune system has found the right balance. So that's a bit the idea that you have to have behind it. So you have respiratory viruses, but you have also, for example, hepatitis. That's also a virus, but that will attack the liver. And that will give a completely different image. Your patient will not be coughing, he will not be sick in the same way as COVID-19, but it will also not be transmitted in the same way as COVID-19. Since the COVID-19 coronavirus attacks the airways, it will also replicate. That's how we call the process of one virus becoming many viruses within one cell. It will replicate within the airways, and it will also be spread again through the airways, so through the throat, through the lungs. People coughing tend to project some virus in the atmosphere. For example, hepatitis, it will be a totally different story since it attacks the liver, and the liver is not really in contact with the outside world. You do not have a risk of catching hepatitis by being in the same room of someone with hepatitis, but there is always a risk with contact with blood or with stool. But as I said, this is a totally different story. So what do we see with COVID-19? There are a lot of theories, a lot of stories going around about how it is spread. Now, basically, I'm trying to tell the easy, basic story here. It spreads through the airways. And does it spread through droplets? Yes, most probably. Is it airborne? Some evidence suggests that it might be airborne, some evidence does not. Now, we tend to be safe here, and we go with assuming that there is airborne transmission. But let me say that this is more a debate between specialists, between the fact that is it in small spread into small droplets of cough. When you cough or when you sneeze, you can sometimes see the droplets come out of your mouth. You can see that there's a stain where you sneeze. Those are the visible ones, but you also have to know that there are invisible droplets. Again, droplets that you could only see when looking at them with a microscope. And such a very, very small droplets can contain a few copies of the virus, which are sufficient to infect one or two cells. And like I said, if one or two cells are infected, then maybe a few days later it's 1,000 cells, and then it expands. But basically, it will go out through your airways. That's why we say wearing a mask protects. It does not necessarily protect the people it does not necessarily protect yourself from getting the virus, but it most certainly protects others if you would have, if you are wearing a mask, so that your droplets do not get spread too far. Combine both. If you wear a mask and the other wears a mask, the transmission is highly unlikely. So it spreads through the air. What does it mean for these droplets? That they can stay in the air for a certain time if you've been into a closed space. It means that some droplets can attach to surfaces also. You can imagine, of course, if you cough against an elevator button and you have a lot of COVID-19 in you, then maybe some virus gets stuck to the elevator buttons, and someone else presses the button, then scratches his nose or does something else, and then the virus spreads again. So those are the main ways of transmission. So basically, without getting too technical about this, what is the best way to stop the spread of COVID-19 is to be as less as possible in contact with potential sources of the virus. A very important detail here, and I've understood that it has been told already a lot of times, you do not necessarily have to feel sick to spread COVID-19. A lot of people spread it before feeling sick, and also a lot of people get COVID-19 without getting sick. That is what makes this virus so dangerous. That is that some people can spread a lot of it without themselves getting sick, but other people in their community or other people around them might get it, might be very vulnerable to it, and then ultimately be very sick and maybe die from it. So that's the dangerous part. If you have a virus that makes you sick very quickly, then you stay at home, and the spread gets relatively easy under control. Here it's not the case. You can spread it even if you don't feel sick. So that's a dangerous one. So these are the instructions from our official governments. They give you a set of key rules, and then those key rules are, of course, the most effective things to do. But my message really is avoid being possibly in contact with the virus. Avoid other people, certainly in these times, certainly when there's as much virus in the population as there is right now. I'm not talking about situations like we had in June or July when, okay, things were okay to slow down a little because there was very little virus in the community, but now it's really huge. And imagine that at least 10 to 15% of the people around us might be infected right now with COVID-19. So if you are in a room with 6 or 7 other people, then most probably one of the others has it, or maybe you have it, and then it gets spread around in this way. So hygiene, regularly washing your hands, because you never know what you've touched, or you never know if you have coughed into your hand that you might touch surfaces. That coughing is a very dangerous one. Stay home when you're sick. It's a very, very important one. Even if you feel a little sick at the moment, it can already be COVID-19. I will talk to you about the serious cases and what it does to the hospital. But before people get to the hospital, they just feel a little sick. So it's very confusing in that way, that virus, that it can sometimes do nothing with you, sometimes make you a little sick, but often makes you also very, very sick. So it's very difficult, even for a doctor, without a test, and especially for a doctor, to know if someone actually has COVID-19, because you feel you have a fever, you have a little throat ache. Well, it could be a common cold, but it could also be COVID-19. So that's very tricky. I don't know if you have some questions about this first part of the talk in the chat already. Things are clear. Okay. So let's say that was more the community part, but let's imagine that you get more sick. We know from these were first estimations, but this has proven to be correct when the epidemic caught on. So we know that more or less 30% of the people who get the virus, the virus spreads within the throat, within the lungs, but it does not spread enough. The body fights it and the body does not overreact. So you actually do not have any symptoms. And what we mean with symptoms, it's what you feel. It's a fever, it's a throat ache, it's a cough. Those are all the very typical symptoms of COVID-19. Typical also for other diseases, but much more specific, we'd say, is when you lose the sense of smell or the sense of taste. That's also something that we see with COVID-19. But you don't have any of that. You're one of the lucky 30%, and it just goes away, and you will not even have known that you got it. But in this period, in these few days, 5 to 7 days, you might infect other people that you come into contact with on a quite close basis. So these are often the people that you know. It's the people you meet at work, it's your friends, it's your family. It's that you often hear the idea, or people feel that you will get the virus from the external world, from going to the shop, from other people, but it's often from people you know, and from people you spend a lot of time with together. So that's for the first 30%. Then you have more or less half of the people who will get the virus, who will get some symptoms. So the virus spreads within the body. You don't feel very well. You lose your smell. You have a throat ache, something like that. But it's mild, it's moderate. You maybe see a doctor. Maybe you think, why, it's a cold. It will go over. And it does go over, luckily. Also, within that time frame, you can infect other people, or you can get infected by someone who has some mild symptoms, but does not want to talk about it. And I have to go to work today. I'm not that sick. It's okay. Still, it's a very dangerous place to be in. So luckily, this is 85% of the cases. Luckily, but on the other hand, dangerously, because it means that 85% of the people who have COVID-19 tend to freely move around and infect others. So in 10% of the cases, you get sick, you get some symptoms, but these are severe symptoms. You have high fever, you have some difficulty breathing, and that's what I put here at the right of the panel. It's the chest x-rays. So that's what we do when we have COVID patients entering the hospital. We do an x-ray of the chest, and what you see above here is an x-ray of a normal chest. You have the bases of the lungs here down. You have the heart, and you have the heart in your chest, of course, and you see the different ribs. And what you need to see is that the lungs are black. The lungs are clear. There's no water, there's no pus, there's just air in that, and that's what you want to see. And air, it does not color on a chest x-ray. It's just hollow. That's good news. Well, with a COVID patient, and that's some images that they've shown on the television, what you see, you can see that with COVID, but you can also see that with other serious lung diseases, it tends to be more white. What is that white? Well, that's water, that's pus, that's a mix of dead cells and your own immune system fighting against that. So that's not good, and it's especially not good because you have this pus, this water inside your lungs. So to make it maybe a bit dramatic, but it's like drowning inside of yourself. And what we see with these COVID patients who come to the hospital, that we have often quite a dramatic image. My radiologist colleagues told us in the beginning of the pandemic, we're seeing images like we've never seen before. And it was a very weird situation because you see that these patients lack a lot of oxygen, a lot of air in the blood. You can see that with the blood test. You can see a very ugly image of the chest, but people tend to feel quite okay. They walk into the emergency room, they say, well, I'm not feeling that well, I'm a bit oppressed, I don't breathe very well, and fever, okay, it might be COVID. You do the blood test, you do the image, and you say, how is it possible that this man or woman just walked in here? So that's a very weird, specific thing of COVID also. But okay, we cannot let you go home, but you feel quite unwell. Doing some mild efforts is already too much. You're very tired, and then we decide to hospitalize. I will get into more detail about what happens then. But actually, it's more or less to give oxygen. Your lungs are not capable of extracting enough oxygen from the air, so we have to give some more to you because the lungs are badly damaged. That's 10% of the cases. And in 5% of the cases, we have to go towards more intensive care and ventilation. There you're that tired and that sick that it's even difficult to breathe anymore. So that's really the very serious cases. When we go in terms of mortality, death rates, no symptoms or very mild symptoms that go away. Of course, there is no death following that image. But when there's a hospitalization or when you're admitted to the intensive care, there's a very significant part of those people who actually die. We've seen that risk factors for that, and it's not that everybody who gets hospitalized dies, luckily, but being obese is a problem for the ventilation and for getting enough oxygen into the lungs. Being a man, an older man, is also a problem. So obese elderly men are typically the ones who do very poorly with COVID-19. To have an image about the risk factors, but on the other hand, it's really difficult to draw a line. It's not only obese elderly men, and we also have relatively young and thin, healthy women ending up in the intensive care unit. So for us, even after a few months of the pandemic, we discuss that the patients that enter the hospital every day, it's very difficult to predict which ones are going to do well and which ones are not going to do well. Hope that is clear. So which are the two options if you enter the hospital with COVID-19? Three options actually. The first one is you're lucky and you can go home. We find that your chest X-ray is actually not that bad, and we think it's not worth it to get you into a bed. We send you back home with some medication to help you suppress the fever, to support you, and then it's normally okay. In some rare cases, people come back, even if we find a mild image. After a few days, they still go down, and then we go for hospitalization. So what we estimate there, once people are admitted into the hospital, and I talk about the classic bed, they get some oxygen, they get it through a mask or through a nose help thing. A few liters of oxygen, it already helps them, they breathe more calmly, and people still are very anxious when they get admitted to the hospital. It's also something that we're very aware of. No visits are allowed also because people are highly contagious in that phase, and we don't want to endanger the family or to endanger other people. And more or less, people are admitted for 1 week. Sometimes they leave after a few days, sometimes it takes a little longer, depends on the age, depends on other diseases. But let's say it takes 1 week to be well enough to leave the hospital, which not means that you're completely cured. Of course, you're well enough to go home, but you've been admitted for 1 week, you've not moved too much, so your muscles, even 1 week in a bed, I would not recommend it to anyone, but it has quite a heavy toll on the body. Sometimes you're admitted to a normal hospitalization ward, but the situation is not going better, it's going worse. So it's even possible after that to get to the intensive care unit. But that's the other part of my slide. What can we do for the patients? Well, it's a virus, and a virus is a very tricky little thing to treat. We have other diseases that are caused by bugs, which we call bacteria, which are a little larger than viruses, and then we can give antibiotics, and that's really a cure. If you have an infection with a bacteria, it can be on the skin, it can be on the lungs. It's not a virus, it's a bacteria, it's something else. There we have medication that works normally very well. Here with a virus, you hear a lot of things in the news that we're testing new medication and some things tend to work and others don't. But in the end of the day, nothing really makes a difference. We know dexamethasone, remdesivir, all the stuff that Trump got, he got even more than that. It might make a difference in certain percentage points. If we go back to this chart, maybe we can get the survival rate, the risk of actually dying in ICU from 50% to 48, but it's not pure. Some of these medications tend to get you for an average of 6 days in the hospital instead of 7. A lot of tests have been done, a lot of things have been tried. We know that there are labs working on medications specifically targeted against the COVID-19 virus. Also, there's the vaccine, which is a completely different debate. Once you're in this situation, it's too late for the vaccine. You have to get a vaccine not to get infected in the first place or not to get hospitalized. But that's a whole other thing. We see that people with COVID tend to make blood clots more easily. So we give some medication to fluidify the blood a little more. So people who take aspirin maybe with heart problems know what I'm talking about. So we give that to all our COVID patients, and we've seen that that has an effect on mortality. So there are less complications due to COVID, but this does not cure COVID at all. So it's mostly supportive care, and that's the bad news. But then we have the intensive care. So unluckily, more or less 5% of the people which we know of who get COVID-19 end up in the intensive care unit. And that's a very difficult story. From our data and from international data, we see that people tend to reside there from somewhere between 5 days to 30 days. So that's when the oxygen you get through a mask or through the nose help thing, I'm sorry, is not enough. People are so tired of trying to breathe that they tend to stop breathing by themselves. The heart is pumping to follow, and it is not going well. And we have on a daily basis 1 or 2 patients who get from the situation of being hospitalized and to have to go to the intensive care because of that. So what we then do is basically put people to sleep so that they don't feel or see what's going on. That would be impossible. And we intubate. So I don't have detailed images of that, not to make this presentation too scary or gory, but what we do there, and that's my colleagues of the intensive care units, well, we put you on a machine that breathes for you. We give you a lot of oxygen, we put you on a machine that breathes for you. We also have other technologies to further support there. If the kidneys would fail, we have machines that can do what kidneys do, and to help for other organs also. But that's very, very difficult. People, what we see there, also to give a sense of why COVID-19 is so weird for us. Other respiratory diseases, when it goes bad, it's possible that you go to the intensive care, but my colleagues tell me that after a few days, they know what's going to happen. Or the people continue to go bad, and unluckily, they then pass away after a few days, or they recover quite quickly. With COVID, you can recover quickly, it's possible, but if you do not, it can take as much as a month to see maybe to recover. So we have now patients who are still in our intensive care units who have been admitted at the beginning of the second wave. So we're really wondering, okay, are they ever going to recover, and what are we going to do with that? So this is a very difficult setting, and that's also why the intensive care units is really a focus of the communication of the government, and really a measure also for us to see what the impact of the epidemic is on the whole hospital system. So there, I think I explained to you what the two options are, and what we do in a hospital. We hospitalize or we go to the intensive care. If you recover from intensive care, and more or less half of the patients do recover, we go back to the hospitalization, because if you've been down for 1 month like that, you're not capable of going home. It's a really lengthy process with physiotherapy to regain some muscle mass, to be able to walk in a normal fashion again. Cannot imagine what it is to be in a bed for 30 days, and especially not in a situation like that. Okay, so that's what we do in a hospital. So where are we at in Belgium at the moment? I think it's interesting to look at that situation also, because things are moving quite quickly, and what is true today was not yet true last week. And it can maybe explain why we get some signals from the government that it's like every 3 or 4 days they've been making the measures a little bit more strict every time. Well, that's because they've seen these numbers and they see that it's really not going the right direction, and they each time try to do something about it. So how can we look at the total situation? Because also there you see a lot of different opinions, and there's testing, but do they test enough? Don't they test too much? So one of the measures, and we'll briefly look into that, but I think that's not, especially for us in the hospital world, the most interesting one. It's the testing. So when people now present themselves to the doctor with symptoms that could be COVID-19, well, we test. We can quite accurately say if you have COVID-19 or not. And we can maybe not look at a virus, but we can find some traces in the nose of a virus that can be detected in a laboratory, and that goes quite well. The testing works well, but it's very, very cumbersome. The way of getting your sample is difficult. It's also a little dangerous for people who have to do it. They have to protect themselves very well. They have to be sure to take some parts of the virus when they do the testing. And also for the laboratories, you have easy tests, you have difficult tests. Well, this is a difficult, expensive test. So that's why it's not easy to organize such a large scale testing for the virus. But when a result is positive, you can be quite sure it's positive. It means that there is some virus, or there has been some virus in the nose where the test has been taken. So what do we see here? We see a curve that starts on the 1st of March with a number of positive tests. And when you look at this curve, you can maybe wonder, oh, look, between the 23rd of March and the 6th of May, there was barely a positive test. What is this epidemic they're talking about? Yes, but back then, there were not a lot of tests. It was a very, very different context of what was happening now. And the virus was only discovered somewhere in January, February. So before the tests were actually produced to be able to be exported to the whole world and to be mass used into hospitals and laboratory, we were past the first wave. So we actually only really tested patients who got admitted into hospitals or who were severely sick. And there were no, back in those days, still 2020, but it seems like those days for us. Um, if you were had been into contact with someone who was positive, would never be tested. So it was really to make the difference. Are we treating a COVID patient or are we treating something else? That's why it seems so low, and that's why you cannot compare testing that was done in March, April, May to what has happened in September, October. And you see here, September, October, it goes up by a large amount because we were really more broadly testing. We were testing people who felt sick. We were testing people who were in contact with people who felt sick, who then also got positive. So we also tested a lot of people who, in the end of the day, never really got any symptoms. But you can see that that's quite large amounts that were performed every day, daily new cases. But for us as hospital, as such, this is not the most interesting one. Also, every time you change your testing strategy, you say, oh, we will test people who come from this and this country, but not this. It changes the whole context. So it's very, very difficult to compare different periods. What the testing did tell us, especially from the end of August, is that it was rising. So never mind which strategy you're following, but if you're doing the same and you're finding more and more positive patients, you have a problem. And that's what we were telling the authorities back then, like, people, this is not good. We're seeing more and more positives. And we know that if you have one person who has the virus, he or she can infect 3 or 4 others, and these then also infect 3 or 4 others. So it starts very low, but it rapidly goes up. So that's the testing. Not really good to compare different periods, but good to see evolutions within a certain period. And for us, very necessary to make the difference between COVID and non-COVID patients. If we want to perform surgery on a patient and it has nothing to do with COVID, we still want to be sure that it's not one of those thousands of people who are carrying COVID without actually feeling sick, because we want to protect our personnel from the virus, but we also want to protect all the other patients who are in the hospital. So that's also a reason why testing is very important for us. But maybe the more relevant measures for us as a hospital now, it's to look at how many patients are admitted in hospitals for COVID-19. So we're looking at patients who are in dedicated wards. We're looking at people who are actually sick of COVID-19 in the Belgian hospitals, starting from the 15th of March. And you see there that first wave that culminated somewhere at the beginning of April, where at a certain time we had more than 5,000 patients admitted in Belgium, in Belgian hospitals with COVID-19. And then when the lockdown worked, all the measures worked, and we could discharge these patients. Some passed away, some got better. And then from the middle of June onwards, we were in a very low, we had very few COVID patients in hospitals. It was also holidays, people went away, no school, nothing. So it was quite calm. We had that little scare in July where the testing went up, and we said, "Oh, this is not going well." You also see that there were some more hospitalizations, but there were some quite some drastic measures in Antwerp, and in other areas, people got more cautious. We realized that, "Why, this thing is not going away," so it went down a little, but then in September went back up. What does this mean? This means that the 3rd of November, almost 7,500 patients were admitted in hospitals. It's more than the second wave, so we have a bigger problem now than we had back in April. and it was also quite significant back then. But which another point which is more scary for us is that this curve is not going down yet. You see it's going up, 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 up. And what you see in that first curve, it has to go to make a turn before going down. And here we don't see that turn yet. So where are we going to end up? We don't know yet. We're just bracing for more patients in the hospital right now. In terms of new patients, we have on the 3rd of November, 877 patients were admitted into a hospital. That's to be generalizing about this is like filling one big hospital every day in Belgium with new COVID patients, people who need supplementary oxygen to go on with their daily life. So these are really, really sick people, especially when the hospitals are filling up. We're not going to admit people who don't really should be. So this is a scary number. And then I talked to you about the intensive care units, where people are put on machines to breathe, to say so. So we also saw quite a high peak with a maximum of around 1,200 patients simultaneously in intensive care in Belgium in April. But what we're seeing now is that there are 1,350 patients in intensive care. Also with a curve who does not really show signs of flattening or going down. And what we do know is that there's a maximum in Belgium of 2,000 beds in intensive care. We already did huge efforts, and I will show you what this means for our hospital to increase that capacity, because of course we also see other patients and other things that COVID at the moment. But we really, really hope that we will stay under these 2,000, because that would be a very big problem. That would mean that at a certain time you will have to make tough choices that you did not have had to make if there were not that many patients admitted into the hospitals. I'm talking about beds. Yeah, of course, you can buy beds, you can buy machines, but it's the people around it. It's the people who have the skills to work with these machines that help you breathe, that can put people asleep in a very controlled manner. Very, very specific skill in medicine, and not many people have that. And also to work as a nurse in that kind of environment, the whole logistics behind it, it's really quite specific. And to get already the capacity to 2,000 in Belgium, it's already quite a feat. And then, yeah, then you have, of course, the last statistic. It's the daily new deaths. We saw a big spike in April in deaths that then went down. But we're also here seeing a curve that goes up. That last point there, that's incomplete. Deaths are registered for a few days, and not all are counted at the same time. So you don't really have to put too much hope into that. It is going to go up. And as we have seen, people are admitted for a few days or even a few weeks in the intensive care before something happens, they get better, or they pass away. So there's always a lagging behind. This curve will go up before this curve goes up. So that's the situation we're at the moment. So what does it mean for us, for UZ Brussels? So we keep these statistics also every day. We have the first peak here, which we saw. You see a rapid increase. So really, in a few weeks, we had to reorganize the whole hospital to be able to accommodate for all these patients, to really separate these COVID patients from other patients who would get really sick if they would catch COVID. So this has been a huge effort in all the Belgian hospitals. I think that's to be noticed. Also, intensive care, we had quite some patients with us. We had 20. So yeah, there are 100 hospitals in Belgium. So you can say that of the 1,200 patients in intensive care, well, we had our fair share of the deal. 20 does not seem like a lot, but it is. I'll show you how much patients we normally have in intensive care, and you spread that over the different hospitals, and it's quite significant. At the moment, these are the numbers of this morning. We have 86 patients in classic hospitalization, which is more than what we've seen during the first week. We have 24 patients in intensive care, and there we have this kind of hopeful little thing that it's not been going up in 3 days, but okay, it's more than what we've ever seen in the first wave. And we also see that this is going to go up. Intensive care normally should follow. And then this is also some kind of intensive care where people are not really put on machines, but still are monitored very closely. So we have created this kind of intermediary situation to be able to handle all the patients. If you add those up, it's 29. And for our hospital, we really have a maximum of 36 positions. So that's something that's happened quite a lot in the past few weeks. We've seen that there has been a huge spike in Brussels of COVID, so we have transferred a lot of patients to the outskirts, really sometimes to faraway places in deep Flanders or in Limburg, Leuven. That's because we try as much as possible to spread